side of the graph, if you see, it has got various parameters. Like the uppermost part of the graph shows elevation maps both for front as well as the back. The middle half of the graph shows exclusion maps both for anterior and the posterior surface, and the lower half shows the difference maps, which is just the difference between the elevation and the exclusion maps. Accordingly, they have graded it as if it is less than 5 microns, it is normal, and between 5 to 7 microns suspicious, and more than more than 7 microns it is abnormal. And similarly, parameters have been given for the posterior elevation as well. In the right hand side of the graph, if you happen to see, there is corneal thickness spatial profile. It is basically the documentation of thickness of the cornea right from the center towards the periphery. Also, we have different parameters like DF, which stands for standard deviation for the front, DB, which is standard deviation for the back, DP, which is the pachymetric progression, DT, which is the thinnest point, centered around the thinnest point, and DA, which stands for the displacement of the thinnest point from the apex. And D is basically the average of all these parameters. So it is a very good indicator which helps us to find out abnormal cases. So pachymetry, do check the residual stromal bed thickness. Corneal thickness less than 480 microns or RSB less than 300 microns might not be ideal candidates for SMILE. PTA, always check PTA. If more than 40%, there is an increased risk for ectasia. Slit lamp examination, like I mentioned before, it is important to check for blepharitis, Meibomian gland dysfunction, allergic eye diseases, and treat them before you go ahead with any refractive surgery. Look out for herpes keratitis, presence of corneal scar, keratoconus, Fuchs endothelial corneal dystrophy, and presence of any cataracts. Examination of ocular surface is also equally important because it helps us to achieve good outcomes. And at our center, we do tend to perform lipiview, which helps us to assess lipid layer thickness, do Schirmer test basically to rule out presence of any dry eye, and non-invasive breakup time to assess the stability of the tear film. Fundus examination is done extensively to rule out any retinal pathology and to look out like retinal tear, detachment, lattices, and holes. So where SMILE holds upper hand over LASIK are cases where there is mild ocular surface disease. As in SMILE, we usually do not tend to hamper the subbasal nerve plexus much. High refractive errors, and I mentioned before, contact sports, military personnel, and martial arts. So to brief it up, absolute contraindications for lenticle extraction surgery are ectatic disorders, pregnant or breastfeeding females, unstable refractive errors, active or uncontrolled eye allergies, exposure keratopathy, one-eyed patients, uncontrolled glaucoma, uveitis, and relative contraindications are if patients is on any hormonal replacement therapy, contraceptive pills, mild dry eyes, past ocular herpetic infection, immunodeficient states, diabetes mellitus, especially uncontrolled, epithelial basement membrane dystrophy, any history of colloidal tendencies, and autoimmune disorders. So proper case selection is very important to avoid unhappy and dissatisfied patients. So do perform a comprehensive eye examination like I have mentioned now to achieve successful outcomes. Thank you.
I think we'll keep discussions at the end. We are going to have enough time to discuss. Any questions will be addressed at that point. So thank you, Prashansa. I'll invite Dr. Sharad to talk about why lenticle. I mean, why do you want to shift from a LASIK to lenticle? And Dr. Kishore, any comments on the first talk? Sharad, you are ready? Yeah.
Hello. Good morning, everyone. After nice presentation by Dr. Prashamsa on patient selection, I am Dr. Sharad, cornea refractive surgeon at Sri Ramakrishna Netralaya. First, I would like to thank Dr. Nitin sir and Prajakta madam for making me part of this wonderful CME. So, why we are discussing about the lenticle refractive surgery? This is my going to be the topic for discussion, and I have nil financial disclosure regarding this presentation. So, we are doing lot of PRK and LASIK, and this is well established that the visual outcomes and results are very good for our laser vision correction patients. So, each of these procedure has its own pros and cons. Like in PRK, it's a flapless procedure and it's technically easy for the beginners. So, but it has flip side that it is associated with the post-operative pain and haze, and it does has a slow visual recovery. While in LASIK, it's a painless procedure and it has a early visual recovery, and definitely it has a wow factor on day one. Patient is very good with the visual outcomes, but there is a disadvantage with this. There are the certain flap related complications. Dry eyes is a major concern, and biomechanically it's weaker than the other procedures. So another option we have the lenticle refractive surgery, which is also known as a laser assisted lenticle refractive surgery or keratorefractive lenticular refractive surgery. Basically, in lenticle refractive surgery, we are creating 2 to 3 millimeter of incision, and through this incision, with the help of femtosecond laser, we are creating a lenticule, and after dissection, we are taking out the lenticule through the 2 to 3 millimeter of incision. In comparison to the LASIK, where there is almost 20 millimeter of cut on the corneal surface. So, what is the benefit of this lenticle refractive surgery when we are comparing with our counterpart, that is a LASIK? Basically, first, it's a biomechanical effects. Theoretically, the lenticle refractive surgery is much stronger than the LASIK because it doesn't have any flaps. The anterior cornea is very stronger, the anterior 1/3 of cornea, because of the arrangement of the lamellae. Any vertical cuts, such as in LASIK flap cuts, it causes the greater reduction in the corneal biomechanical strength than cut parallel to the corneal surface. So, in lenticle refractive surgery, the anterior stroma is uncut. So, it does gives the biomechanical strength to over the post-operative cornea. There are very limited options available to analyze the biomechanical effects in clinics, such as ocular response analyzer and Corvis. So there are these studies which has done, and this is a study in which there is a one eye has been underwent a SMILE and other eye has underwent the LASIK surgery in the same patient. They have analyzed the biomechanical effect with the help of ORA, and in post-op both the procedures there is a reduction in the corneal resistance factor and corneal hysteresis. So there is no significant difference observed in this study. But however, there are the other studies in which the study does shows that SMILE had lesser effect on corneal biomechanics than femtosecond LASIK. So each of these machines have its own limitations. But in mathematical models and in finite element analysis, it has shown that any lenticle refractive surgery procedure is much more better than the LASIK flaps. So, second point of discussion is the corneal subbasal nerve plexus. In normal cornea, as we know that in anterior part of the cornea, the corneal nerves comes from the periphery towards the center, and it penetrates the Bowman's membrane, and then it forms a subbasal dense plexus, which gives rise to the horizontal and vertical branches. In femto-LASIK, as we have seen here, that at the edge of the flap, the subbasal plexus have been cut. After whether we have created the flap with microkeratome or the femtosecond LASIK, then we apply the excimer laser, and which again destroys the underlying stromal subbasal nerve plexus. Whereas in SMILE, as we are seeing that at the edge of the cap, the most of the subbasal nerve plexus are preserved. However, at the site of the incision, side cut, that is 2 to 2 millimeter incision, the nerve plexus are reduced. This is well demarcated in the confocal microscopy. The first top panel, just observe. This is the after the SMILE procedure, the LASIK procedure, in which there is a clear demarcation at the flap cut. And the second image, the topmost, it shows that there are the preservation of the corneal nerves, whereas in the site of the corneal side cut incision, the corneal nerves have been cut. So basically, this demonstrates that definitely corneal subbasal nerve plexus density is much more in SMILE compared to the femtosecond LASIK. With this, the corneal sensation have been studied. The SMILE procedure or any lenticle refractive surgery procedure preserves the corneal sensation. The corneal sensations drops in first week, but again it regains back to normal within a 3 months to 6 months period in a SMILE compared to the LASIK patients. So in LASIK patient, it comes almost 6 months to 12 months to regain the corneal sensations. So with this knowledge, obviously, when there are the less corneal nerves, there will be the less blinking, and you will have a more kind of dryness. So there is a meta-analysis between the SMILE and femtolasic patients. So how these parameters varies. In first week, there is no difference except the corneal sensation, but as the follow-up period progresses, the SMILE better in OSDI, the T-but and corneal nerve density as compared to your counterpart, the femtosecond LASIK. This is interesting that functional optical zone of the SMILE versus the femtosecond LASIK. Functional optical zone is in SMILE is larger than the femtosecond LASIK. So this is very important in case of mesopic light condition, where you will have the more nighttime glares, halos, and the in this study they have prospectively followed the patient over a period of 3 to 7 years, and in which in both the groups the functional optical zone do reduces, but it is always larger than your femtosecond LASIK. So the visual outcomes are much better with the lenticle refractive surgery compared to the femtosecond LASIK. And in long run, the femtosecond LASIK does induce the spherical aberration in post-op periods. So if we compare any new procedure, so we would like to compare it with our routine procedure like femtosecond LASIK. So how are the visual outcomes? These are the results of the SMILE, in which the post-op uncorrected distal visual acuity of 20/20 or better has been achieved in most of the patients, range from 60 to 90% of patients, and all corrections are within the 0.5 diopters in most of the 90% of the studies. And there are the multiple meta-analysis which does shows that the both SMILE and femtosecond LASIK are safe, efficacious and predictable, and they have studied the meta-analysis of ocular aberration as well, and in which both the procedure does induce the higher order aberration, but in SMILE it is less than the femtosecond LASIK. Last month, the results of the Schwinn et al. Smart Sight has been published in the Cornea Journal. So with this very interesting finding, what we are getting on day 1 post-op, 82% of patients are having the 20/20 visions, and in the same study they have demonstrated that more than 35% of patients are having 20/16. This finding is interesting that in SMILE we do and other refractive surgery, there is a slow visual recovery. If we are achieving 82%, that is a good one. There are very few, 2% of patients have loss of 2 or more lines than the preoperative corrected distal visual acuity, and most of 95% are having the uncorrected distal visual acuity within 1 line of corrected distal visual acuity. Similarly, 1 month and 1 year result are similar. the predictability, how is the surgery outcome. So this is a scatter plot and regression analysis of the refractive changes attempted, and the refractive outcome achieved at 1 month and 1 year has been compared, and the results are falling within the line of best fit lines, and 98% of the patients are having the visual outcome within 0.75 diopter. How is the refractive stability after the vision correction with the Schwinn-Detos? Over a period of time, if we see the this line diagram, there is a stability over a period of 1 year, not much of change in refraction. So it would be better to see what are the complications. Basically, these two are different techniques, so each will be having its own different complications. First, the LASIK. As we know that there are the multiple flap related issues. Dry eyes is significant up to 90% of patient, and corneal ectasia risk, and multiple studies have shown that it's much more than the SMILE. What are the complications with the SMILE? The first is a difficult lenticle extraction. Studies have shown up to 1.8 to 9%. So there is definitely learning curve in the any lenticle refractive surgery. Surprisingly, the infectious keratitis has been reported 0.39% compared to your femtosecond LASIK, and the corneal ectasia is lower compared to femtosecond LASIK. So to conclude, why the lenticle refractive surgery? Basically, it's a safe, effective, and predictable visual outcome compared to your counterpart femtosecond LASIK. It is biomechanically much better, and there is a better preservation of corneal sensation and less dry eyes. It has a large effective optical zone, and it has absent flap related complication, and there is a least risk of ectasia. Thank you.
Thank you, Sharad. One thing I really found good with the lenticle was its cut is so small and there is no flap, so surgeon can sleep really well. There is no worry about striae or folds. So next day it's very difficult to find that cut also. It's that subtle. It's very small cut. So it's an amazing technology. We are loving doing it. But before we proceed with the next part of the session, I would like to thank people who have come all the way. I want to thank them, and a small token of love from our end. So I will request Suhas sir, my father, to felicitate our chairperson, Dr. Shashi. So I am presenting with this Puneri Pagadi. Now this Pagadi is presented to people who are intellectual people and whom we to show our respect. So. इकडे हे पुढे पाहिजे. वर या ना. स्वप्न
So, hello. Yeah. So, Dr. Shashi Kapoor is the chairperson for today's session. We would really like to welcome you, sir. He's a director of Anideep Eye Hospital, Villeparle, and he has he's a pioneer. Plays a pioneering role in excimer laser refractive surgery for myopia.
Thank you.
Thank you, sir. Next up, I would like to invite Dr. Kishore Pradhan. He is the founder and medical director of Matrika Eye Center, Kathmandu. He is the first refractive surgeon of Nepal, and he is the first person to develop smart sight laser procedure, and he has key opinion leader for ATOS femtosecond laser.
Pleasure.
Thank you so much, sir. Thank you so much. Next up.
We will.
Thank you.
Introduce.
Next up, let's invite Mr. Dominic von Planta. He is the CEO and Deputy Managing Director of Schwein Technologies. He's an MBA graduate
this
from
cap
France.
is given to the intellectuals and people who contribute.
Thank you very much.
So he has a immense knowledge and experience in management-based positions. So together with Shrine, he has a vision to pursue in making laser treatment as the first choice of treatment for correcting refractive errors. Thank you so much for being here. We also have the president of Maharashtra Ophthalmic Society, Dr. Thorat, with us. Thank you, sir, for gracing the occasion. I would like to call up
Then
Thank you so much, sir. I would like to call up next Mr. Mars, who's the sales head of Shrine.
Mr. Lars, please. It's Lars. He's head of sales. Please come.
Thank you very much.
So this is shawl. We honor people with this. So.
Thank you very much.
And Mr. Lohit, the marketing head of Shrine.
Yes, Rohit. Thanks for coming all the way. इकडून. Yes.
So Dr. Nitin and Dr. Prajakta are directors of Sri Ramakrishna Netralaya.
Yeah.
Thank you everyone for coming here and gracing the occasion.
Yes, thank you. Dr. Swapna is an excellent cataract and a refractive surgeon, so she is part of our team. So continuing our scientific session today, Dr. Prajakta is going to tell you some salient features about this ATOS. And you have seen from Dr. Kishore's papers that we all think that the lenticle surgery vision recovery is slow, but he's proven with his experience and modifications that almost 80 to 90% people are 6x6 next day itself. And I have experienced that in his center when I was there, that his patients are 6/6. So we are on our way. We have done close to 50-60 cases now. We are pretty confident doing dissecting lenticles now. And then you have to learn to improve your dose and all, what Dr. Prajakta will discuss now, that how we can modify our dose and fasten up the recovery of our patients.
Screen enlarge करो. ठीक है, it's okay. It's okay. Next. So I'll be talking about this intelligent femtosecond laser technology for lenticule extraction, ATOS from Schwind. So these are some of the unique features of the machine, and I'll be talking about few of them in my presentation now. The most important feature is that machine has got intelligent eye tracking and cyclotorsion compensation, also automated pupil recognition, and we take images on the serous topography. We export those images to the ATOS machine, and when we take the patient under the laser, we see this kind of a image. So in this image you can see that automated pupil recognition has been done by the machine, and you can see two in cases of patients having large angle kappa, to avoid the edge glare, especially at night. This low dose concept is very important. Why is it important? Because it causes minimal strain on the eye, it provides better visual acuity in the early post-operative days, and it also provides better resolution with lower corneal reactions. Many times energy is confused with the dose, but dose is different than energy. Dose is the area over which energy is delivered. So this is the formula for calculation of the dose. To understand this concept, you should understand the terminologies like track distance and spot distance. And in this picture, you can see that the spot distance is the distance between two adjacent spots given by the laser, and track distance is the distance between these two lines, adjacent lines. So in the first image, you can see that energy is low, but the dose is higher. This is because the track distance and spot distance is lower, and the spots are very symmetrically spaced and they are compactly spaced, so dose is higher. And in the second picture, the energy is higher but the dose is lower. This is because the track distance and spot distance is more, and all the spots are asymmetrically spaced. So this asymmetric spacing of the spots is the feature of ATOS again. Why do you want to have the low dose? Because it helps all the layers of the cornea. It causes accurate epithelial remodeling. In the Bowman's layer, it gives you less wrinkles, so there is less scattering of the light. And in the stroma, it causes minimal keratocyte activation, minimum necrosis, phagocytosis, and less corneal reaction, and better visual outcome post-operatively. So you can also play with the settings like energy, spot and track distance for the anterior cut, posterior cut, edge cut and all. We don't change it for each and every case. These are all fixed settings, but we can. These are our current settings. These settings differ from place to place. The settings depend on the temperature of that place or humidity, and they change from OR to OR. So you cannot use the same settings for every OR, and you have to customize your own settings. The lenticule geometry is also very specific in ATOS. It tapers out in the genuine transition zone, and there is no edge cut and no minimal thickness. So there is less epithelial remodeling and less regression. So the lenticle is very thick in the center, and it is very thin in the periphery. Almost it goes down to zero, and because of that there will be less regression in future. So this geometry of lenticle is very different from that of other lenticular machines. Of course there is a bit of learning curve because of this, but this is very helpful for less regression. Another feature is that it has got a curved patient interface with integrated suction. So it is very comfortable for the patient because there is less IOP increase due to low vacuum level. It causes minimum deformation of the cornea because it is like the shape of the cornea and it sits properly over the cornea. There will be minimal deformation of the cornea because of that. The PI connection is very easy. You have to just click and start the suction. It has got an integrated vacuum tubing, and one size of PI fits all the eyes. You don't have to change the PI according to changing diameter of the cornea. So it reduces the complexity of handling, logistics and storage. So these are some of the features of the ATOS, and this was our first ATOS session for which Dr. Pradhan had come all the way from Kathmandu for guiding us. Thank you.
So now I'll be talking about the surgical technique, and after me Dr. Kishore will enlighten us with his experience with this laser. In the next presentation, I'll also be sharing our the struggle in the early stages, because as Dr. Prajakta pointed out, that each place and each machine has different settings for energy. So it takes few cases to really know what's best for your machine, your technique, and So energy settings are very critical. So after you learn the surgical technique, next very important thing is your energy settings, which Dr. Prajakta already highlighted. And the very good feature about this machine is dose, because if you are managed to give the least dose to the cornea, your patients are going to be recovering very fast. So that is very important. So I'll just take you through the surgical technique, and first I'll show you my case. So this is how the ablation takes place. It's a very fast laser, and you can see there's a centrifugal. So this is a posterior refractive cut. So the whole cut is, all the cuts are done in 30 seconds, and then this is the cap cut. So this is centrifugal. So each machine has their own pattern. The advantage of this cut is you don't get black spots in the center, because as patients become little anxious by the end, the black spots won't be there in the center, which is a very important zone. And then you can see the entry cut is done. So whole process is pretty quick. The machine has a good amount of vacuum, so we have not had any suction losses till date, which are problems with some other platforms. So it's a very safe procedure with this. So now how the actual separation is done, you score the entry cut, and then you see I'm tenting up and moving in. So I'm making sure that I'm on the anterior plane, then I'm going straight, and you can see that I'm dissecting the posterior plane, and now I'm coming up again. The trick is to go over the previously dissected area so that you know exactly that you're in the right plane. I'll just, you saw what I did. I went tent up, dissected anterior, then I went straight, I dissected posterior, and then I went up again, and when I feel a resistance over the previously dissected area, I'm 100% sure I'm in the right plane. This is very important, because in initial phases, this is the most difficult thing to do, is to identify the right plane. And many times you feel you're in the right plane, but you have already dissected posterior before anterior. So we have to make sure you dissect anterior first and then go posterior, because if you do posterior first, your lenticle is stuck up, and then so I'll share videos also how to come out of that Chakravyuha, but still if you do it smoothly, you'll be very happy. So now with a spatula, I'm dissecting the anterior. You can see how smooth it is with this machine. And then you dip down and go straight. Here you go straight, you'll land up posterior. And how do you know whether you're in posterior? You will feel a little resistance again. Like if you have done anterior and then gone posterior, and you don't get any resistance, you know you are in the wrong plane. So you know that you have dissected posterior first. So you should feel that resistance. So this surgery is different from LASIK. It's all about the feel. And feeling that resistance is very important. So now I'm doing the posterior part, and you dissect, the whole thing is done. And then see, again, one thing I would like to show you, just a minute. You see, when I go in, I don't dissect the whole left side, I leave little area undissected on the left side, because when I'm dissecting the other side, this is an anchor for me. Otherwise, the whole lenticle will move and fold. So it is very important that you go in, you leave a little area here, you finish dissecting on this side, and then finish the whole thing. And now you see that the lenticle is folding. So now I can take it out very easily. See, it's all come out, So you don't have to do too much of an instrumentation. Now it is very important that you get used to this smooth process, because every additional swipe is going to add a day to your patient's recovery, So you have to be smooth here. And so don't fiddle too much in the putting forceps too many times. Everything is going to delay recovery. So the faster you are, the better your patient will look the next day. So this is a deferred life surgery. This gentleman happily agreed to his video to be shared for the conference.
My name is Bharat Chaudhary, and I am 29 years old, and I live in Sigurs.
So we took a lot of points from Matrika when we went there, the way they counsel, they are so particular and so meticulous with counseling. You have to tell patients prior what to expect, otherwise people are anxious and scared. They try to move their eye, head. So it's important that you tell the patient what to expect. So here, when I'm doing the surgery, I have given instructions so you can listen to that. But many times we instruct prior also, that we tell them what to expect when they go in.
So this is a 29-year-old male, and his refraction in the right eye is -7.25 with -1 cylinder at 165 axis. Vision is improving to 6/9, and in the left eye his refraction is -7.25 with -0.5 at 10-degree axis. Vision is improving to 6/6. So we have entered all the parameters. Optical zone in the right eye is 6 millimeters. Total zone is 6.8. Cap thickness is 120 and cap diameter is 8.2 millimeters. Length of the incision is 3 millimeters, and we use this London Vision Clinic's nomogram, which we overcorrect the patient according to his age. So this patient in the right eye has been overcorrected by plus 0.5.
So there is a London Vision nomogram, which again Dr. Kishore shared it with us, and so you basically make patient little more hyperopic than you want, because with the process of regression, then patient lands up with 0 in a week or 2. So again we tell the patient that reading might be little strenuous in the initial phase, but things will get clearer over a week or 2. London Vision nomogram usually it is age dependent. So if the patient is younger, you induce more hyperopia compared to a patient in 30s and 40s. We induce laser hyperopia. So that is how, and it's a formula where we just feed and we get the output. But after doing 40-50 cases, we realize that when London Vision nomogram says plus 0.75, we only do it by 0.5, because ATOS compared to other lenticle machine has a laser regression, because as Dr. Prajakta explained, the age design, the lenticle design, the regression is much laser than other platforms. So we kind of use London Vision nomogram, but we slightly overcorrect little bit laser than that, because we have a laser regression.
The final value comes to -7.85 with -1.01 cylinder at 165-degree axis. The residual stroma is 277 in this case. So let us start the case now.
So this is how the machine looks. The cone, you can see the patient lies down there, and there is a little joystick on the right side with which you can control the movements of the bed. And you see it through that microscope, and the little screen on the left side of the scope is where you can see what's happening to the eye. We are just going to put anesthetic drop and do the whole procedure. We will do right eye first, followed by left eye. Okay? So when I bring this table up, you will start seeing 3 lights straight ahead. That little yellow light that you will see straight ahead is the light where you should keep seeing. So that yellow light is your fixation light. So just keep seeing at the yellow light, and once this little cup will touch your eye, this yellow light will move away. But you don't have to worry about that. Just keep looking in the same direction. So you keep looking in the direction you were seeing before. So you will feel little vibrations once laser is firing. But again, as I told you, it's painless. It just takes few seconds to finish that. After that, I'll remove the cup and I will take you little up, and then I will look at your eye from the microscope and just remove that lenticle which is already separated. So the whole procedure is going to be only few minutes, and you need not worry. You will be absolutely okay. It's close. Because of gentle suction, it's a pretty painless process. Nobody complains of any pain or any discomfort, and you make the patient little relaxed. You tell them it's just air bubbles that is separating the tissue. There is no cut as such, so they are relaxed. Because it's very important they are relaxed at this point. Because if when the suction is on, if patient moves and you are halfway, then you can't continue the procedure. So that is why it's very important to relax the patient at this point. But it has a decent amount of suction, so we have not had a single suction loss till.
Chin up.
So you position so that your cup doesn't hit the nasal bridge, you know. So few people have very long nose, so you have to little tilt the patient's head away. It's a very elegantly designed cone, and it goes and sits on the cornea very well. So you just click and it's ready. The machine laser immediately calibrates once you click the that PI in.
It's a very small instrument to keep your eye open, Bharat. Yeah, looks good. It is very important that when I tell you that not to move and that the procedure has started, it's very important that you don't move your eye, okay? Okay, sir. So just relax and keep looking the way you are looking.
So there is a joystick with which you can lower and so there is the view on the screen that you will see, and the Myers will start now as Dr. Prajakta described. There is a circle in the center which is 200 microns. When the two crosses match and your cross is in that central circle, you know that your visual axis is perfectly aligned with the laser. You will see that cross. Yeah, you see that? And when the other cross is in the center of that little round circle, you know you are within 200 microns of the visual axis, and that is when you start the suction and the laser starts.
Relax raho ekdam.
So you can see this has a quasi telecentric optics.
कुछ seconds ही लगेंगे, बढ़िया हो रहा है.
So you can see that little thing that is protruding into the cup, you know, that is the laser probe, and it has a feature called quasi telecentric ablation profile, where your peripheral spots are also perfect. So because it goes close to the cornea and fires perpendicular to the cornea, you have a very uniform and a nice cut, you know. So again, this is very unique to the Atos.
You're doing very well, Bharat.
This is the cap cut again.
Don't move, you're doing very well.
So it takes 30 seconds to finish everything, and that's pretty quick.
बहुत बढ़िया भरत, बिल्कुल नहीं हिलाना है.
It has a very robust recalibrating.
Very
it keeps
good, almost
calibrating. Because Dr. Kishore had mentioned it, laser can make a lenticle in 6 seconds because it's a 4 megahertz laser. But why it takes longer? Because it is rechecks, you know, the rechecks they do to make sure that the lenticle is being made properly. Takes 30 seconds, you know.
Very good, हो गया almost. Very good. See, that's all. हाँ, अभी चलो मैं अभी फटाक से lenticle निकाल देता हूँ. You'll be.
So patient might be scared at this point because he's not seeing things.
Fine,
you have to tell him that everything is okay. And now you move the bed little up, and you see through the microscope. You put a parakin again. It is important to stabilize the globe, because if he's moving when you're dissecting, you can get cap tears, you know. So I'm doing the same thing that I showed you in the last. So initial phase when you're learning, you have to make sure you're in the right plane, because that is the only thing that you have to learn. So I'm stabilizing the globe, and now you can see when I'm making a swipe, I'm also dissecting the whole thing. So you don't have to do multiple swipes there. You have to be quick, because more swipes you do, the recovery will be slower. Now I'm in posterior, you can see I'm feeling that resistance. I've gone to the left, I'm not dissecting the whole left side. I've finished right, and then I'm taking the. But even then you can see there is a little adhesion there. My lenticle is not totally out. So now I'll take a forceps and I'll just do the lenticulorhexis.
Don't move, Bharat.
It is, when you're doing this lenticulorhexis, you have to go to the periphery near the attachment. If you are in the center and you try to pull it, it will easily tear it. It's very thin. And you know that lenticle is stuck there at the upper side, the cap side. So I'm not able to get that angle from left. So I'm now going from the right. Now I've caught it and I've peeled it. So the laser maneuvers you do in the interface, the faster your patient will recover. And that's it. I mean, you really don't have to watch the interface. It's all good. You can. It's better to make sure that your lenticle is intact, because if there are any cuts, you can always go back and retrieve the remaining lenticle. These are very, very thin. I mean, when you are around 1 diopter, 1.25 diopters, they are very, very thin lenticles. In initial phase, it's better not to go for very low diopters. So moderate myopia will be the right patients. And you can see, I'm sure now that my lenticle is nice and round, and I have dissected everything. And just make a simple swipe there. Just dry the entry bone, and you are done.
Okay, you can see my face. Abhi, it will clear in a day because अभी dissect किया है ना. So अभी आज शाम तक heal हो जाएगा वो सारा.
They are happy. They are pretty happy next day. So our results so quickly, because whatever we have done, whatever cases I had eye tracy data, I have taken those cases here, and 77 eyes. You see our visual outcomes are excellent at a month and 6 months. Not that every patient of ours was zero. This is interquartile range. So some of our patients initial phases had 0.25, 0.5 residual, because we were setting our nomograms right. We were setting our energy right. But now we are getting much better results because both these things are addressed now. We know how much to overcorrect, and our energy parameters are there at the right point. So, but if you see overall, see the patients we have selected, 4.5 range, not very high cylinders. The highest cylinder we have done is -7 sphere with -3 still, and patient has done extremely well. So this machine does treat astigmatism very, very well. You see, you get a very good distance visual acuity. Of course, these are young patients. There are some patients on the right side because they are the patients in 40s, and we had counseled them that they will need a little reading power. If you see aberrations, the corneal aberrations have slightly increased, but if you see total aberrations, coma, trefoil, spherical aberrations, secondary astigmatism, there is no significant change in those. Very important slide, you see Strel ratio indicates the quality of your optics. You see the pre and post, the Strel ratio is better now. That shows that the quality of vision outcome is excellent in these patients. Even if you check MTF 0.6 to 0.5, although there is a slight change, let me tell you, 0.5 indicates a very good optical system. Anything beyond 0.3 is a good optical system. And mind you, these are young patients, and so both in Strel ratio wise and corneal MTF wise, we have had very good outcomes. So this indicates that the outcomes were a good quality vision. So thank you so much for this. Now next I would like to so next is Dr. Kishore. So he looks like a model. He has a brain of a scientist, and he has got a hands of a great clinician. So he's all in one, and our mentor for this surgery. So that's the talk we are all waiting for. त्यांचं ह्याच्यातच आहे.
Can you fix it for me? Yes. Good afternoon, everybody, and thank you so much for coming to listen to me. He's full of praises for me, but I'm not a very good speaker. And I have to be very, very modest to say that more than me, it is the R&D department that does most of the things. Yeah. But what are we presenting right now? I have 3 things to present, so.
The oops cases only we'll do later.
Okay.
But rest of the things you can.
So I can do my.
Show your life and your experience with the.
So I can start with my presentation?
Yeah.
Okay. Good afternoon once again. Maharashtra has always been very, very close to my heart, but we have all religions. Sometimes I feel I'm in Maharashtra, in Nepal itself, because I live in have you been to my house? No. So I live very close to this temple called Pashupatinath temple, and it is crowded by Marathis. You have the Maharashtra bus, all these, and I feel I'm in Maharashtra most of the I've taken them to Pashupati temple and then, and very happy, jolly people, you keep honking, leave the road and say, yeah, beta theek ho, and I'm always Maharashtra's always been very close. I've come here many, many times, and my sister studied here. I studied in Karnataka. And lenticular extraction again, I'm very, very lucky that Prajakta has already spoken half the things which I have to speak. So this makes things very easy. But is there anybody over here who is doing lenticular surgeries besides Dr. Nitin? Anybody who is doing lenticular surgery? You are? With which laser? With the VisuMax. You should come forward. We should be more interactive. Come. I worked a lot with Zeiss before, I've done 2 clinical trials with them. So VisuMax is a great laser. So what I understand over here is most of the people over here are in the phase or in a plan to start refractive surgery. But I'm sure everybody is doing a lot of cataract surgery. Yeah? So do you think you started cataract surgery in one day? No. Like cataract surgery, lenticular surgery is worse. The person who is doing lenticular surgery over here, the VisuMax, he will tell you, it is more tougher than doing cataract surgery. I'm telling you. But when you look at other surgeons doing surgeries, you feel, kitna easy hai, it's so easy. Andar jao, lenticule nikao. But then I was in Singapore just about 2 weeks back, and the surgeon who had done 50,000 LASIK, he said, I can't see anything. I can't see. Kishore, when do I start seeing the lenticule? After all the dissections. It is a tough surgery. It is not easy. There is a learning curve. But over time, things have grown better and better and better. You have more surgeons to guide you. There are more. So today my real talk is evolution of femtosecond laser. I started refractive surgery back in 2010. And my first refractive procedure was SMILE. I had not done LASIK, and I was the guy. That time there was a trend that you had to do 2,000 LASIK, 500 flex, and then you could do SMILE. But accidentally I managed to do SMILE, and I found LASIK so difficult. And suddenly the trend, my professor was Dan Reinstein, London Vision Clinic. He used to keep poking me from behind. Do this. I said, it is so difficult, LASIK. Lift the flap up, do this, put the eye track on. Lenticule is so easy. Lenticule is so easy. And then I was the guy who started around going all over Asia, like in China. You don't need to do LASIK. You can do SMILE directly. You can do lenticular surgery directly. And every year I've become quieter and quieter. I used to talk so much before. Now I've become quiet. I realize lenticle surgery is not easy. It is getting tougher and tougher and tougher and tougher. Back in 2012, I had come to Narayan Nethralaya in Bangalore when we were installing. Dr. Kapoor was also there. And I was always saying, it's so easy, lenticle surgery is so easy. We cannot call it SMILE because now we have so many different platforms. So the SMILE is with the VisuMax. The Schwind is the Atos is called Smart Sight. And then you have the Zemer, and then you have Elita by Johnson. So everybody, they've given it different names. Elita is called Silk, okay? So let's start now. So you see, even after all the evolution, you see the last person there, he's not perfect. We are still a long way to go. So this is a video of okay. This is the video of a lenticular extraction by Schwind Atos. But have you seen the video of the Visumax Zeiss, the Zemer, and the Elita? Is the same. It is the same thing they'll show you. So you will always feel, oh, you've taken the lenticular, small incision, no cap. But the things over 10 years has changed so much. Have you just go and see lenticular extraction with Zemer, they'll show you the same. Schwind, same thing. You know, Zeiss, the same thing. It is, now the understanding the whole thing is very, very important. Now since you are all about to start refractive surgery, it is very important. The first thing I would say is, people talk about femtosecond laser. Oh, he has a femtosecond laser. Wow, 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 wow. He has a femtosecond laser. You know, this is what the trend is now in India. This guy has a femtosecond laser. But are we getting rid of our excimer laser? No. We cannot get rid of our excimer laser. Can we even get rid of our microkeratome? No, we cannot. So femtosecond laser, yes, there's an advancement, everything is there, but the old things you cannot get rid of. Okay? Let's go through some things now. Okay, so this is already explained, so I'm going to explain it one more time. You can ask me any question anytime, but since you've made me the center of attraction over here, you can just stop me, ask me this, probably I'll know, probably I'll not know. So we also have marketing, you have sales, Dominic is there, they also know a lot. Though they're in the management, he knows a lot, okay? So first thing you understand is the spot size. This is going to be quite a long talk. If you get bored, just let me know, I'll speed up. But what you have to understand about a spot size is back in 2006-07, Zeiss, they started off firing the femtosecond laser. It's like an atom bomb. Yeah? So the femto is very close to the YAG. You do YAG capsulotomy with cataract surgery, something like that. You put a bomb, so something like that, Zeiss realized, for example, if you use a 120 pulse energy, now energy is lots, okay, so there's so many things, you'll come across so many energies now. So when you talk about the pulse energy, is like you're firing a spot. I'm just giving you an example. For example, if you fire a spot of about a 120 nanojoules pulse energy, boom, suppose you get a spot size of 4 microns. Suppose. Okay? And then you get a spot size as big as that. But then if you reduce the pulse energy is when you're reducing the pulse energy, so from 120 you're going down to 80. You get something like this. Okay? So the size cannot be controlled by you. You cannot control the size. The spot size, you understand? The spot size cannot be controlled by you. What you can control is the energy, the pulse energy. You can increase or decrease the pulse energy. And there's something else, the spot and the track distance. The spot distance is not the distance between the two spots. It is the distance between the center of two spots. Okay? You can control that also. And the track distance is like a racetrack, you can control that. So when your energy increases or decreases, your spot size will change, but the spot distance and your track distance will remain the same. So now again, let me show you how we were started. When we started back in 2010 and 11, with a 120 nanojoules pulse energy, with a 4 micron spot distance and a 4 micron track distance, this is how it was. The first spot the second, the third. This is how the laser was cutting. Okay? Or from anywhere. And then if you look at it, this is the cornea, and this is the refractive cut. The lower cut is called the refractive cut, and then you have the upper cut, and the amount of cornea above the cut is called the cap, and below is the residual stromal tissue. When you take the lenticule out, you get an empty space like this. Okay, but if you look at that, you see how rugged the floor is, how rugged the roof is. You manage to get a lenticule, but it's still rugged. Okay? Then again, not only the pulse, we learned how to calculate the power, we learned how to calculate the dose. So dose and power, again, the energy is different things. Okay, we'll come to that slowly. I think first you understand only the pulse. All right, so this is the formula for your dose. This is what you created. And then, when we started off with the Atos back in 2018-19, we started with the same energy levels. 120 pulse energy, 4 spot distance, 4 track distance, and we were getting the same results. We were fighting with Zeiss forever and ever. Give us eye tracker, because the Visumax did not have an eye tracker. We wanted an eye tracker, we wanted cyclotorsion, this, so many things we wanted. And Atos came with everything. Atos has an eye tracker, Atos had cyclotorsion. So first thing that came was the eye tracking and the cyclotorsion. But after fighting so much and getting the eye tracker and the cyclotorsion, the results were slightly better, but not as good as what we expected. We always thought if the Visumax had an eye tracker and cyclotorsion, the results would be much, much better. But then we realized we got the stuff, it's not happening. So we thought the only thing we could think of was reduce the energy. And the first thing that came to our head was to reduce the pulse energy. Okay? So when you look, we reduce the pulse energy. Like, see, look at this now. We reduce the pulse energy. When you reduce the pulse energy, your spot size becomes smaller and your cuts become like that. Okay? And we look at the diagram over there. This is your lenticule that you've created, and when you take that out, this is much, much smoother. But if you really look at it, the dose, the roof and the floor are much smoother, but you have an area of uncut cornea. You see that? That area over there that is not cut. So if you go and dissect, you can't dissect. You'll be tearing the whole thing apart, and it was a disaster for us. We managed to do, cut, but then the vision was even worse. So very simple, like if you're all doctors, very, very intelligent. What do you need to do now? Bring that closer, right? Yeah? Very simple. You have got to bring the whole thing closer to each other. So what we did was we reduced the interspot distance. That's what, right? And then we reduced the track distance. Then what happened? It became even worse. Yeah? See, this is how you all are thinking, right? अब क्या करना है इसको? Just पास में ले जाना है. You could. So the many laser companies still do it like this. Why? When you bring the whole thing closer, the repetition of the tracks, the number of spots that you put in, is as simple as doing phaco. Your phaco machine has a phaco power. You can reduce the phaco power and carry on doing surgery for 1 hour 45 minutes, and tomorrow morning you'll have a white cornea. So this is what the whole concept is. You could have very, very low phaco energy, but tomorrow your cornea is white. Nobody knows why. So my phaco power itna kam tha, and everything was so easy, nothing. but then your time is so important, the phaco time. So the whole amount of energy that is going into the cornea is so important. So you see, we've done bad things in our life, like to actually understand what to do next. So this is what I said. Instead, what we did, we increased the interspot distance. Yeah? Reduce the pulse energy, and we reduce the track energy. So what happens in between the pulses, in the spots, another two spots could fit in. So we reduce the track, increase the interspot distance, and the dissection was easy, and the total dose is also very, very little. So this is, now it became an asymmetric treatment. Your spot distance and your track distance, they're asymmetric, they're not symmetric. Okay? So this is what I'm trying to show you now. From 120 nanojoules, we managed to go up to 80, and we started playing around. Wait. If you do all that, you will not understand the whole thing. You listen to me properly, okay? From 120, we went down to 80. We played around with the spot and track distance. 4.5, 2.7. You see over there, what is written is the same result. You're getting the same result. We managed to reduce the pulse. Then we realized there's something more, like, we need to reduce something more. And then, so this was what we are doing, 4.7 with an 80 pulse. The dose over here is 750 millijoules per centimeter square. We reduced from the same pulse energy. We increased the the interspot distance even more, and also the little bit of a track distance, and reduced the whole power of the power and the dose. So from 750 we went down straight to 440. So most of the time now we are operating around 700 and below 700. So my sweet spot is around 600. That's where we play around. So there are so many studies, like Rohit Shetty would say, the corvis is very important. Sometimes very strong corneas, or OR is very important. Very strong corneas will have tougher dissections. Weaker corneas are easier. Sometimes I get worried. Sometimes I do surgery, oh shit, is this patient going to land up with an ectasia or something? It's a very scary thing. So this is just an explanation. You see over here, you can reduce the pulse energy from wherever to 42, but then 1 micron and 1.2, but the total dose over here is more than 2,100. The ELITA is working like this. This is why day one ELITA is always struggling. Okay, and the other side you have is the Visumax 125. This is around 700 millijoules per centimeter square. And then with the Atos, you have 80 nanojoules, 6.7, 2.7 spot and track distances. So this is where the dose is very low, good dissection. On the other side you have, this is the first picture I showed, 80, 4.3, 4.3. The dissection is very, very tough in this, if you have a pattern like that. And then again, 80, 12 point, a big asymmetry is also dangerous. Otherwise, sometimes your treatment can go on for 2 minutes. If you have a 12 micron interspot and a 1 micron track distance, it'll go on, the track it has to go on and on and on and on. Okay? So the time can be very long. So on the right side, what I'm showing you is 83 and 6. The track, this is a very fast treatment, but the dissection is very, very tough. So you have to understand, you can make the laser very fast, tough dissection, you can make the laser a little slow, easy, all these things. At the end, what we realized is the dose and the power that we put into the cornea with good centration is the most important thing that gives you great results. Okay? So now, since you all are thinking of, I understand many of you all are thinking of starting refractive surgery. Okay, let's cut this out. She has already spoken about the laser part. So one thing that Dr. Nitin also mentioned was the quasi-telecentric optic. and the scanner, which is in the center. It's a spinning scanner. It comes down very close to the cornea. So it is not firing from the top. So if you fire from the top, in the periphery, there's going to be deflections. So this is firing, it comes down, the spinning head, the scanner comes down, and it's always firing perpendicular to the cornea. So your peripheral cuts as well as your central cuts are equally the same effect. Like if it's tough in the center, it'll be tough in the periphery. If it's easy in the center, it'll be easy in the periphery. So you will not get lenticular tears and tags. This is one of the complications of many of the things. Like, you know, my lenticule automated till last year, now it is automated. Automated means you take a scan, put it in the Atos, the scanner recognizes the pupil, it recognizes the visual axis, and all you have to do, as the video was showed, there are two crosses, and cyclotorsion, all you have to do is align it on top of each other. So offset is something called as a treatment offset. Suppose the visual axis is somewhere else, it gives you a treatment offset. All you have to do is align. The alignment is so important. It goes and treats right on the corneal vertex. And cyclotorsion compensation during and after docking. You don't have to mark your corneas, you know, like there is cyclotorsion, like when you're standing up and when you're sleeping. Sometimes it can go almost up to 20 degrees. I'm going to show you that. So the new thing that has come up now again is Centrax, okay? Centrax is a new software, like, you know, putting the two crosses aligned on top of each other is not easy. You take the laser head, you put it on the cornea, it takes a long time. Before we didn't have any eye tracker, or we used to think, wahi pe attack, probably thinking that it is there. But now when you see the crosses, and you have to align it, and the patient is moving the eye, it is not easy. It's taking longer than normal. So what happens with the whole pressure on the eye, and the suction and the resuction and all that, you're getting subconjunctival hemorrhages, and your intraocular pressure is getting very, very low with all the optical pressure. It's almost 200, 250 grams on the eye. You know, if you're taking it too long, the intraocular pressure goes very low, and your dissection becomes very tough. So what Centrax does is when it gets very close, you can dock. And if it's green, the Centrax will go and treat on the visual axis. You don't have to waste too much of time docking, like, you know, you just go and it is done. So it is all done by vector analysis and things like that. There's another whole big presentation on that. So this is, I think these videos are already present before. What you have to understand over here, what you need to see is the cyclotorsion can also be displayed right on the screen, the amount of cyclotorsion. You can already see it's measuring. You see, this is the longer video. You see the yellow circle is the treatment. It is not in the center of the cross. That is because of the treatment offset. When the moment the patient starts squeezing, the eye will rotate in different directions. You have to see. And you can see it's either in this direction or in the other, clockwise, anti-clockwise. And you can actually measure the cyclotorsion on the table. And even after docking, the treatment, like, you know, you can treat, post-docking errors can be treated by Centrax. This is not my video. Okay? And the funny part is, what I was trying to show was, you need to do single sweeps and all. And I was showing it to a guy whose video it was. That guy said, no, this is my video. Like, you know, he's a Chinese guy, a surgeon from China. But I try and do as, I think this is what it should be like. I've never been able to do it like this. This is single sweeps. So what are the benefits with low energy, all this? The minimal strain to the eye, better and faster visual recovery, better resolution, lower corneal reaction. So you will see In my past, when I was using the VisuMax, you will get white opacities in the interface, especially when your energy is high. There's star-like, stellate opacities in the interface. They don't affect the vision too much, but then somebody else sees your patient, you see white opacities always in the center. So the lenticule geometry has already been discussed. I might skip this slide. But again, it is thick in the center, thin in the periphery, goes right up to 0 microns, has a transition of about 0.8 millimeters. That's a big transition. The VisuMax has a transition of 0.1. This is 0.8, and the transition is also asymmetric. So asymmetric is mainly associated with the centrax as well as with your angle kappa. So if you're moving somewhere else, the other side of your transition becomes slightly bigger. That's mainly to fight your night glare and things like that. So in the periphery, the epithelial remodeling, the regression, is very less with Atos. So comparing it with the VisuMax, it is almost 25 to 30% less of epithelial remodeling. So the nomogram that he was showing is actually 25% undercorrecting already. So these were the results back in 2021 when we were still using high energy symmetric spots and things. So we were very, very happy to be like, we were getting like 82% for 2020 in 1 week. And we were very happy. These are the normal results. But now our results, if you look at it, 42% of patients are 2016. Many of our surgeons don't even dare to do LASIK in one eye and smart sight or smile or whatever. But now the results are the same. If you look at this has already been presented before. 40% of the patients have gained one line. Day one, you're talking about day one, okay? And then with astigmatism, most of the patients are within 0.5 diopters of astigmatism. It's very simple. The more corneal swelling, the more astigmatism you induce. And day one, the astigmatism has come down very little because the swelling is little and the patients are much, much happier. So, it used to be like, yes, I can see 20/20, doctor, but when will my vision come back? That's what the patient will always say. With LASIK, patient be, wow, I can see everything, doctor, I can see all the fine things. But with the smile, we would go like, yes, doctor, I can see, but when will my vision come back? Like, they were never happy, like, because that swelling is there, like, So if you look at that, 100% of patients within. And then we did a study where we took about 86 parameters in the laser, and we tried to learn. Sorry, I'm taking a little longer. I'll try and finish up fast. We took about 86 parameters to learn what are the things that actually affect the visual acuity. We have intrinsic and extrinsic factors. The intrinsic factors are the laser, the parameters are the optical zone, the larger the better. Then the cap thickness doesn't affect the vision. Laser energy, the larger the energy, the worse. Now you understand that, right? The spot distance, larger the better. Track distance, smaller the better. Dose, larger the worse. Power, larger the worse. Power is something else again coming up. Asymmetry, larger the better. Less cross-talking means they don't jumble up and attach on top of each other. On the extrinsic factor, you have to understand this is your side, okay? Not the laser side, your side. The date of birth. Younger patients do better because firstly they have more endothelial cells, the swelling goes off faster. Treatment date means how many patients have you treated? I was just looking at a YouTube video, which Dr. Sri Ganesh had put in 2012 in YouTube. And that was a video after I had done 1,000 smile patients. And now when I look at it, like, God, I was doing that even after 1,000 smiles. My surgeries are totally different. So the treatment date, expect your first 100 patients to be different. You will not get the same result. You will think like, oh, now after 40 patients, I'm doing this, and then my results are still changing. I don't know, sometimes one eye I'm getting good result, the other I'm not. Something is happening, if you look at it after a year or something, you'll realize that your surgeries, you laugh at your own surgeries. Okay? The spherical equivalent, the larger the better, in the sense because of the minification. When things, large minuses can minify your image, so when you get rid of it, you gain a line. It's the same thing with the hyperopic. You tend to lose a line. Cylindrical power, larger the worse because of the optics. Target, again, younger patients do better because they have more accommodation. They can accommodate more, so many things. Accommodation can reduce your pupil size, so I always try and keep them on the plus side. You know, the little bit of plus, they accommodate, the pupil is smaller, so many things come down immediately. Keratometry, steeper, worse. Because the steeper it is, the more you have to press on it, there's more deformation, and you can have worse corneas, worse results. Epithelium, more the irregularity, worse it is. Like if you have a corneal scar, if you have an epithelial defect, ABMD, all these things really affect your post-operative visual acuity immediately. So this is just an electron microscope study. This is from Korea actually, and I'm so happy. They're showing my slides, I'm showing somebody else's slides. The world is like, it's become like WhatsApp thing, like, you know, since I don't have an electron microscope. So what are the new features that has come up with the Atos is we can start treating simple astigmatism. Like, you know, you can treat a plano. Otherwise, you always had to have a small minus, the minimum of a minus 0.5. Now you can have 0 and a cylinder. You can treat that. Okay, and then you can keep the laser on a standby mode, which is like, you know, you don't need a lot of time to start it up in the morning. Then you have corneal rings are available, like, you know, for your keratoconic patients with the Atos. And I don't know if I want to show this video or not. This is
transepithelial PRK with Atos femtosecond laser.
Reduce that.
This is one of the easiest procedures to do. Even if you land up with a complication, you could just make a lenticule on your cap. So this is a patient where we made a lenticule on the surface. All you have to do is hold the lenticule with the epithelium, a transepithelial PRK.
Let's not talk too much of it. You see the post-op corneal topographies day one, they're amazing, okay? I think everybody's getting bored of all this. So in conclusion, I would say Atos is doing very, very well. And it is, I think, one of the best lasers now of the 4 or 5 platforms that we have. And it's totally different. The results are great. I'm very happy to be a part of this. Thank you so much. The funny part is I'm a vegetarian for many, many years. And he told me he's a vegetarian. I took him to all the vegetarian restaurants. And last night he was eating chicken, so that was, I was a what? Like, you know. Over here we are taking Rinku to the laser and then with a little bit up. So Rinku, even if I block your light, let me just, okay? Don't move it. So let me explain a treatment offset over here. The treatment offset is, you see this yellow circle is about 200 microns. So this is not in the center of this white cross over here. So this is down, this is the left eye, so this is down and nasally. It means that the visual axis is superior temporally. Okay? It doesn't mean that the treatment is there. So when you bring that circle to the center, you are actually treating superior temporally. You're not treating there. So this is the treatment offset. So the laser already puts an offset somewhere else, just opposite of where the visual axis is. It knows your visual axis is there, it will make an offset opposite to that. So that when you bring that offset to the center, you're actually treating on the visual axis. Head, okay? Open your mouth and no matter what. So I'm going to put more and more anesthetics and I'm going to check how cooperative you are. I'm going to put more anesthetic. Check, always looking straight. No, let's whatever she has. Touches the eye, you'll feel a little pressure and a little. I want you to look 1 millimeter. Okay, I'm pausing again. So it'll tell you all these things over here. So it'll tell you all the energies over here. The energy is around 700. So this is just to show something else. You have the cyclotorsion, the treatment offset, and you have something over here that tells you the amount of pressure. It has to be on the green. So it tells you the amount of pressure on the optical system on the eye before you start suction. So if it is below that or above that, even with suction, the laser will not work. These are all checks and balances of the laser system. I'm about to press the button. So this is the cyclotorsion bit and the visual axis. Very good. Absolutely steady. So you see a lot of these over here. These small things are all micro sponge particles. So they can give you small black spots. But if you look at it, it was not docked. So when you were there, Dr. Nitin, I would have redocked and redocked and redocked to get the two crosses aligned on top of it, right? Remember, we were taking so much of time because before we didn't have eye tracking. Now we have it, we have to do it on the spot. But it takes such a long time just to put that two crosses. It is not easy. Before we thought, no, now we have the eye tracker and we'll do it this. It is not easy to put that. Even after docking, you will see this, and that's where Centrax comes into play. Centrax will take care of everything. So yeah, I mean this is all, the camera is from the top. Looks so very, very smooth. If you look at this, let's go back. So you have the scanning system in the microscope. So you will not see from the microscope. The VisuMax you can see from the microscope. You cannot, because the quasi-telecentric optic is in the center. So what it does is, the different camera from the top will be taking the thing, and it always looks that it looks like it is decentered, because the camera is taking a picture from this side, not from the top. Okay? So the treatment looks a little decentered, but it's actually the camera is from the top. The anterior cut. So everything is down. Okay, let me show you the surgery. Then I realized one thing is Dr. Nitin and me, we are operating exactly the same way, like, you know. Oh, so now you'll feel a little pressure from my side and a little pushing and pulling. I'm going to clean up. Ekdam na chalaune, otherwise you get a scratch otherwise. Very good. Leave it loose. Taller ni. So now I'm entering, try not to ahana chalao. Very good. Ahana chalao taller around. So I tell the patients, if I scold you too much, don't worry, I will not beat you, but over the lenticule. I'm going. Then I go under the lenticule. And then you under feel the resistance. Over the lenticule again on the other side. This is my video, so you see how different it is from the Chinese surgeon's video. Eh? So as Dr. Nitin said, every rub is 1 day extra for your recovery. Now we know that we are over the lenticule. Means don't move your eye, you get a cut. I really love scaring my patients. So what I have is a small tear in the cap over here. So even after whatever number of surgeries, we don't play God. We are doctors, you know. So see, I have a small cap tear at the edge over here. Like mayonnaise. So the surgery is done. What I'd like to do is iron the cornea with a dry sponge. I don't know if I've shown it here. Absolutely smooth. What we do, I just iron the Bowman's membrane. Looks absolutely smooth. So what happens is, if I want to check, what I'm looking for is any mud cracking. Look down towards your foot. Okay? So mud cracking means, you know, when the mud dries up and you get cracks on the mud. So mud cracking is when you decenter, like your two your lenticule is not aligned and then you decenter, it's like that. And then they wrinkle up. But like if they are properly on the visual axis, they go on top of each other and it's very, very smooth. So if you see mud cracking, you know tomorrow this guy's vision is not going to be very good. But if it is on the dot and it's very smooth, you know, I don't need to see the patient next day, something like that. So if you have decentration at top of your right eye. All right, Rinku, you still alive? Rinku, ठीक sir? Yeah. Not around. And another thing I tell the patient is like the girls especially, I tell them is like, your eyelashes are all there, don't worry. Like, the girls are more scared of the eyelashes than the surgery and the pain, like they can't put mascara after a week. Okay? Thank you so much. Okay.
So I'll show my cases and then you can.
Yes, absolutely. I'll take this off.
So I'll be sharing the difficult part now because you saw all the.
Can you put it? I have one more talk.
It takes almost 20-25 cases to dissect it properly. So here I'm going to show. Oh, I think it's all. So this session is called Oops in Lenticle Surgery, and it is to share our struggle because I know many of you want to start doing this surgery. So I want to show you some things that you should do and what you should not. So as I told you, energy setting is very, very critical, and I'll show you the first session where we found that our laser settings were still not in place. So you can see how tough the dissection can be if your laser settings are not proper. So you saw my previous video of live surgery where you could see that I could just swipe, but here you see the struggle. That is because our energy settings were still not set in the initial settings. But now once we have it right, we know we can. Now you see this number of swipes and things is going to delay your visual recovery. And now you see me going into the posterior plane. Yeah, it's fine. So when you are going posterior, if you have too much of a resistance, you can also have false planes, because if you put too much of force, you can just enter some wrong plane and you are going to have a problem. So this was the energy setting, but then eventually in few cases then we got it right. Now secondly, this case we saw that there were no bubble formation, again energy issue, you know. So but my application said, sir, doctor, it's cut, you go ahead. So although you can see that I was not very sure whether I should proceed, but he was very confident that cut was made. So I went ahead, but you see it was difficult, you know, because again energy setting issue. So this was happening for first 1 or 2 sessions, and this is I think probably a second session video. So you can see it's tough, you know, it's not easy, but unless you have a perfect energy setting, a good separation, you're removing your lenticle becomes tough. So I'm just peeling the lenticle off, and it's now when you're peeling the lenticle, it is important that you go to the base, in the periphery. You know, if you try to go in the center and pull it, you'll tear it. You go to the periphery and peel it along the circumference. So if you try to pull in the wrong direction, you'll easily tear the lenticle. The next is black spots. Now black spots can be because of if you try to redog again and again, your meibomian secretions will just go and sit there, and if you don't notice that, this is what you get, you know. So it's better to abort, clean the interface and then go in, you know. Because here I did not realize, again I was very new to this whole thing, I did not realize there were meibomian gland secretions sitting there. And you can see the black spots. Now black spots are essentially non-cut areas because laser is not passing through that area. This is the posterior refractive cut, and you can see the number of black spots, those are there. And then you can dissect this, but again your visual recovery will be delayed. You know, the patient is going to have some edema next day. You can see that my struggle here. And these are the cases where you can easily have a false plane, you know. So I managed to take the lenticle out, but it was a struggle. So it is very important that your interface is very clean, you know. See, I mean a posterior, you saw there were more spots in the refractive posterior cut. Here it's so difficult to dissect. So yeah, at the end I managed to take it out. Now simple thing is don't pull. If you pull like this, you'll tear it, you know. It's better to push it in and just peel it circumferentially. Now it comes out nicely. Now this is where what happens most of the times when you're starting, because it takes little experience for identifying the correct plane. Now you see I'm just going like I'm doing a routine thing. I think I'm anterior, I'm doing a nice sweep around, and now anterior is done, and when I'm going to do posterior, see there is no resistance. I'm just going very smoothly. So now I know that was I had gone. So now this lenticular axis things comes to the rescue. You see with the forceps I'm just peeling the lenticle, and I'm holding periphery every time. You don't try to do at one go, you know, you have to hold, rehold, do it bit by bit and remove it circumferentially, because it's a very thin tissue, let me tell you. Then another posterior entry case where I've used a little different, interesting and a good instrument called Jod dissector. It's Dr. Jod Mehta from Singapore National Eye Center. He's devised this instrument with Katina. So you have different instruments in your armamentum which you can utilize every now and then whenever there is such situation. You can see I'm dissecting, everything is going smoothly, and I feel I am dissecting the anterior plane. With experience, you basically have to follow the edge of the lenticle, you know. With experience, you know exactly where you are, the clarity of instrument that you are seeing below the cornea. If you are anterior, you see the instrument is little more clearer than when you are posterior. And then you see there is no resistance here. See, it's going smooth, all smooth, you know. So I have done. So with the spatula itself, I try to see whether I can go little anterior, but no, it's just too smooth, and I know I have dissected the posterior first. So now I try to take this and try to go little anterior. You see, I have to tent up and try, and then I manage to find the edge here. And now with this Jod dissector, I go in and try to dissect more, and see I'm feeling the resistance, and I have found the anterior plane. So, and now with the edge, I'll just go and peel it. You see, I can see a little edge on that side, and I'm slowly peeling it. Again, you have to be careful here, because if you have a tear, it will be very difficult to find that little remaining lenticle, and it won't be easy, you know. Dr. Kishore showed me a very good topography based way to how to detect the retained lenticle in one of the cases. When he was here, I did everything. So after he went, I was okay doing everything. So when he was here, I took a chance of doing everything. All the complications. So you peel and you are done. So although you go posterior, there is a way of salvaging the case, and again you make sure that your lenticle is intact, because you have done a lot of maneuvering here, and then we are fine. So again, when you do lenticular axis, you should know how to, what not to do, you know. So this is a video that what you should not do when you are trying to do a lenticular axis. So I have not edited too much, because many of you are trying to learn. So you can see that now the posterior posterior plane is being dissected, and again anterior one to make sure that you are in the right plane. So this is a double, it's like check and check again, you know. You dissect, little bit resistance here, but you still manage to go all through. It's better to do least maneuver in the center, you know, because every time you go to the center, you are causing some. Then posterior, you are feeling the resistance there, you know you are in the right place. I'm not able to forward here, so we'll just bear with this. You dissect, dissect, dissect. So every time you have to leave some tissue on the left side, otherwise you are going to fold the whole lenticle. You go to the other side now. So these are our very initial first, second session videos. We are able to dissect. So the edge is a little sharper. So with that, when you are not able to dissect, you just use your edge of the spatula to dissect through. And we have to make sure that you dissect till the edge. But when you are trying to fold the lenticle, it's not coming. So it's not folded. So now we'll have to take it out with it's partially folded. You can see it's only partially folded. So you go in. Now this is what you should not do. If you pull here, you'll tear it. As I showed you prior, now you try to remove this again, but no, it is stuck. So it will not come out. So you take the spatula again. Now is the right, you are going to the periphery and trying to dissect. Try to do the lenticular axis. Yeah, now this is better. Now you are able to remove it. If you pull it, you will tear it. Yeah, but now again you are still away from the edge. You should not do this. You will tear it. What I should have done is gone back to the edge and now it's out. So if you don't go to the edge and peel circumferentially, and if you just try to pull in the center, that's not the right thing to do. And again, one more video. You need this lenticular axis very often in the initial phase because you are not very through with the whole technique. Many times you are not able to separate easily. Then this lenticular axis really helps you take the lenticle out. Seeing same video, these kind of dissections again and again might help you in the wet lab. So that is why I have not edited those every time. So posterior plane, I can feel the resistance, and I have done one thing here that you should not do is I have dissected the whole left side in a one shot. You can see I did not leave an anchor on the left side. Now you see what happens. See, whole lenticle is moving now. When you are trying to dissect the other side, the whole lenticle is moving. You will find it difficult now because lenticle has folded, the dissecting there becomes difficult. So now again you have to take the forceps, peel it and take it out. So don't try to dissect without leaving some tissue on the left side. You will have a whole lenticle folding on itself. And then you manage to take it out like this. And the final one, similar to dogwort. So this was a very recent case. After Dr. Kishore showed that he gets a capture, then I don't feel guilty at all getting a capture. This is a fairly recent case. See, capture there. So if your angulation is not right, you have to go parallel. If you try to tilt any time, you'll get a cap tear. But I managed to continue. You can see that there is a cap tear on the right side. I could finish it, but then I made sure my angulation was right. Good part is these cap tears heal beautifully. Next day you will hardly see them. So you just iron them nicely and put a BCL. Next day you don't see that cap tear that well. It works. It really heals well. So thank you. So I'll request Dr. Kishore to show his interesting cases.
Dr. Nitin, these guys are all new people. If you show them too many complications, they will not do refractive surgery. Next day they'll all run away. And the other thing is like, before I started refractive surgery, I was in retina. I just met one retina person.
Oops in lenticule surgery.
So he told me to make a video. I made a video out of it. Then actually, it's already spoken. You see, right now, I think 70% of the refractive surgeons are retina and glaucoma surgeons. The cornea guys are too scared. They're scared of corneal layers, they're scared of the thickness, they'll talk about this, they'll talk about infection, they'll talk about dryness, they'll talk about epithelium, and then it is the retina surgeons. The retina guy is getting hand movement vision after 3 hours of retina surgery. And when he does LASIK, he goes, wow, I don't want to do retina anymore. Do we have retina surgeons here? Yeah, see? The day a retina surgeon does refractive surgery, once he will leave retina. That's it. He is Avastin, lasers, buckle lagao, ye karo. And yeah, retina is attached, that's it. But then it was the same for me. One refractive surgery, and I said, yes, this is what I'm doing now. Okay? And even the glaucoma specialists, everybody. But the cornea guys, even if they are refractive surgeons, they'll start saying, oh, the cornea is so thin already, you don't want to mess it up. I don't think I want to be a refractive surgeon, So, and again, many of you, I'm not trying to discourage you or anything like that. I don't want to show, if you really look into my complications, even I will faint. I have seen such bad ones, like last year in Dubai, I was talking about complications. The people are like, Kishore, please shut up now, don't talk too much. You're scaring the old ones also, So I think, I'll just say a little bit, few things over here, what I'm really scared of.
We, as surgeons, we don't play God. So we always need to understand that things can go wrong. So things that really worry me during and after surgery, one is suction loss. Unintentional getting sucked in during treatment because you can have a tilted lenticule. Not finding the edge of the lenticule is another nightmare for the surgeon, not being able to take the lenticule out after finding the edges, like after dissection, and the lenticule is totally rotated. You can get severe mixed astigmatism. You can get cap tears, infections, and ectasias. These are all my fears. So this is a video I will show you. The biggest fear when you're learning how to do surgery at the beginning is a suction loss. Are we scared of suction loss? No, we are not. So when I know...
So let me just interrupt over here. In refractive surgery, what is the chance of you getting hit by a lightning? In Mumbai, what is the chance of you getting hit by a lightning?
1 in a million.
Yes. So I think going blind in refractive surgery is also 1 in a million. I think it's like that. Unless, I'll show you one where things can go wrong. The conversion rate, like our biggest competitor, I do about 1,000 patients a year, my clinic, okay? But all the optometrists are against me, the whole country. They say, this guy is stealing our patients. Firstly, the optometrist is our biggest competitor. You have to tell them, how many glasses are you selling a year? How many glasses do you Maharashtra is selling in a year? Probably crores and crores in a month. Yeah? In Nepal, it's like more than 1 crore. And I'm doing 1,000 patients. Where am I stealing your patients? First thing you have to say, where am I stealing? 1,000 patients. And you've done 90 lakhs glasses have been sold. 1,000 patients. The second fear is the complication. What if something happens? Have you ever seen an ophthalmologist have a refractive surgery? Yeah? Very few. the fear, what if something happens? So that fear should not be there. Now there is a treatment for everything. No matter what you mess it up with, there's always something that you can do it. Unless like you're really, really unlucky. I will show you some things.
That more than 90% of 95% of the cap has been done, I can actually go with only the cap treatment.
This is my fellow actually.
Only a cap treatment, all right? So this patient, the cap was about 135 microns. So we did a LASIK on this patient, but you can also do a trans-PRK, or you can also make another lenticule on the cap with a 100 microns cap, but you have to be about 30 microns minimum above the old cap, old refractive bed.
So did you understand what I said? Like you can do, you get a suction loss. People are talking about suction loss, ho gaya to kya ho gaya, barbad ho gaya, nothing. You can just do a PRK, it'll give you so good results. You can do a LASIK on it. The only thing is that Atos has other softwares like, you have only side cut. Like for example, at the end, you get a suction loss. You can do only a side cut thing. You also have softwares where you can convert the cap into a flap. You can do subcapital. So many things are there. If everything, like, you're thinking like it's too scary to do something, you just do a transepithelial PRK or a PRK on top of it. Sometimes you might have to wait, but many a times when I get a suction loss, I don't wait. I just wait for the bubbles to clear and I go do a trans-PRK immediately. So this is another patient where the conjunctiva was sucked in.
So what we have here is, you can see the conjunctiva is getting sucked in from the superior side, and the surgeon, this is a fellow of mine, doesn't know whether to continue, not to continue, and when you can see
the incision is on the conjunctiva.
Is the side cut is on the conjunctiva, and then I take over. So what you have to understand, the eyeball is very, very soft. I try and look for the incision which hasn't happened. And what I do is I've taken a 15-degree blade and I've just slipped it into the Bowman's membrane. The moment you slip it into the Bowman's membrane,
so the Bowman's just, the moment, epithelium is about 50 microns, the Bowman's is 10. The moment you cut the Bowman's, you will enter the same plane, exactly where you're supposed to be. So this is what I was doing.
You can actually easily get into the plane. And then once you're in the plane, you can actually go into the different planes, the upper and the lower plane. But then this is about less than a 2 millimeter incision, so I've used a flap lifter instead of a dissector. The surgery was safely done.
See, I always have a retina forceps there to save.
The other options would be to do LASIK on this patient. A side cut only treatment is also there. Or you could also do a trans-PRK.
You could do so many things. It's just
the best part is you can do a trans-PRK with an Atos now. So this is a patient, not from Nepal, somewhere else. This has been one of the persons who I've been training. And if you look at this, I don't know where he learned how to dive into the center so that the patient could see. This is when you land up with, if you think you're in a, if you want to go into the wrong, you land up in the wrong plane. Now the surgeon thought he was on the anterior surface, anterior cut.
But this is a 40-minute video. So you can imagine, you can attach a retina in 40 minutes, but the surgeon has done 50,000 LASIK. And then doing a lenticule was like, he never thought it would be so bad, He went on and on and on and on. So the thing is, you think you're on a different plane, and you want to find the other plane, and you can't find it. That means you're already in that plane, so you got to look for the other plane. So most of the time we go below the plane, below the lower cut, thinking that we're on the upper cut, and then you dissect and you want to find the lower cut, you're already there. So all you have to do is understand when you can't find that, means you're already there. You got to find the other one. So this is what had happened to the surgeon. He went on and on and on and on.
Anterior interface, whatever you call it, and then he was trying to, and even if you don't make out in this, if you think you're in the anterior and you're trying to find the posterior and you cannot, you're actually in the posterior. So what was done, what we really need to do is very, very simple.
Just do a corneal topography, see the OCT. He'll tell you which plane you were in. Very simple. If you can't find one plane, you've dissected one plane, and you can't find the other plane, and you don't know which plane you were in, just go take the patient to the OCD, do the OCT, and he'll tell you you are up, or above, or below. And then you know what you need to do. You know? So as I said, since I'm a retina guy, before I used to cut the cornea, make it into a flap and look for the lenticule, and I don't do that now, but then before it was, you can actually find it anyhow. But this person, what he did, he put the patient in the car and
to do a scan and see.
Took him to
So which
another
plane have you dissected?
another smile patient, another smile surgeon, to another clinic. And shit, you know, I struggled for 40 minutes, and I took the patient to his friend, and took him not even 30 seconds to take the lenticule out. And he thought he's such a bad surgeon. And the whole question is, when you start panicking, you don't see anything. The moment you don't find one plane, it is like a PC rent. When you're in cataract surgery, you get a PC rent, you start panicking. The first thing you need to do is stop, close your eyes and relax. Go to the bathroom, pray to God, come back again. You know, this is what you need to do. Okay? With a cataract surgery, you cannot do that, but over here you can. Okay? Tell the patient, "Tum coffee peete raho, main aa raha hoon. Sit down, Bhagwan, please help me." You don't know the patient is praying and the doctor is also praying.
And even if you don't make up, that I'm scared of is,
This is something which Dr. Nitin has already showed. So this is actually what had happened to him. He dissected and he was in panic mode, and he can't see anything. He doesn't know where the lenticule is. I say, anybody can see. You can see the lenticule, can you? Can you see the lenticule? But if you were the surgeon, you wouldn't have seen the lenticule. Pakka. You'll be so threatened with lenticule. I'm telling you.
sometimes you have a tough dissection. So after you've
So what was done was
just moves. So
sorry,
this is
cap tear.
cap tear during surgery. It can happen if the patient just moves. So I always hold the patient with my left hand. So some surgeons don't like to hold the eye, but
I like
to hold the eye because this is what will happen if the patient just moves the eye, or if you're putting too much of pressure on the eye, you can tear the cap.
But I never put.
So after surgery, most of my
I never put contact lenses. So you put the cap back and then it's okay. So these are the most dreaded
feature. This is one of our patients that we happened in Kathmandu recently, and had keratitis with hypopia and all that. It was a disaster. So something you have to be really careful is if you've done a very rough surgery, or you have to be very careful with blepharitis, and you have to be very careful with whatever thing that could have caused this infection. But luckily, unluckily, we had similar case in my second eye center where the cornea melted and perforated and do a penetrating keratoplasty. But this.
So again, the cornea specialist did a PK, and the patient has almost 612 vision now, -8 and a 2-cylinder. So this patient in Kathmandu is about 6'9". So what I'm trying to do, when you look at this really must have made you feel like, oh, this is it. But then keratitis healed, and again, thanks to refractive grass and all those things, they actually work, actually. I thought it would never work. Refractive grass and things like that, they actually work, and they make the corneal scar thinner, and the patient's vision has actually improved.
patient healed up pretty well. And if you look at the video of this, the dynamic video of this OCT, the whole cornea was wide, but then the cornea was -8, about 612 now, corneal scars, the gap. So you see a lot of fluid over there, inflammation,
This is again something
corneal
else.
scars.
It's the VIP
So this
syndrome that
is
you say.
an OCD diagram of
This is one of the most important persons in Kathmandu, the Prime Minister's right-hand man's wife, like, owner of 22 companies, it took me one whole year to treat her. So VIP, it'll happen to doctors, ministers, or somebody like this. So what happened, she had a flap dislodgement, and what you see over there is an epithelial ingrowth with some fibroblastic tissue. We scraped that 3 or 4 times and we put the flap back. I even brought this patient to Bangalore. Dr. Rohit and me, we worked on it, we were on and on, up and down, and at the end what happened?
fibroblastic membrane growing onto the gap. So you see a lot of fluid over there, inflammation, DM folds, and these can give you so much. I wouldn't put it so it
So
can
this is the
actually
patient.
melt.
So what happened was, that patient, the cap started melting. So you see, it started melting from one side because the nutrition in the cap was obstructed by the fibroblastic membrane. She had hand movement vision. It was a blended vision kind of thing, the other eye was for near, the other eye was for distance, and the distant eye, she had hand movement vision, and we were on and on and on. The whole cap started melting. And when the whole cap melted, she got 20/20 vision after that. She's absolutely fine. It took me one whole year for the cap to melt. So this is what I'm trying to tell you guys. Refractive surgery is better than retina surgery. So if you're for it, best of luck, all right? Thank you so much.
So,
Yeah, one more talk, yeah?
So I already requested Mr. Dominic to put an intra-op OCT on the Atos. So, and he said yes. It's such a wonderful company that he's running. It's a leader in the refractive surgery, and it's very nice of him to come all the way for the CME. So we would like to learn from him that what's next for this machine Atos femtosecond technology.
Hello? Okay. Thank you very much. So, after all these interesting talks, sorry to keep you busy with some additional, more high-level perspective maybe, but thank you very much, Dr. Nitin, Dr. Pradakta, for the opportunity to present here. Sorry for keeping you a few more minutes from lunch, but I'll try not to take too much time. And thanks for Kishore, who said that despite the fact that I'm in management, I have a few things to say, so I'll try to honor that comment and provide you with some content. So I know the focus of today's session is on lenticle, but as we know, I mean, the lenticle is intertwined with the refractive surgery in general, so I'll take a bit of broader perspective and not only speak about lenticle. First, I think, as we all know, myopia is increasing. It's mainly driven by lifestyle, I mean, screen time or time spent indoors, the near distance of screens, and of course there are other challenges like presbyopia, aging population, and so forth. So, as we know, the main treatment options as Kishore mentioned earlier, main treatment options is glasses and contact lenses. That's still by far number one. Refractive surgery is increasing, but we are still starting from a relatively small base of somewhere of 3 to 5%. And the opportunity is tremendous, actually. I think it's, there we have still, let's say, the intraocular refractive lenses, which are growing as well, still also a relatively small base. So the question is, what does it take to convince more patients, and how do we increase refractive surgery 10 times and get to the 50%? So I think let's say the competition is not in the room, is not here in the room, and is not, the competition is basically not other refractive surgeons, or for us, not other companies. If we look at the innovation day before, so the innovation session before ESCRS, they did a survey and asked surgeons actually what is your what's the biggest element, or what are the biggest elements preventing refractive surgery. One was actually the financing, which I think the costs, which I think I don't fully agree, actually we'll get to that later. But the other, fear is still a big element. So for patients, just the even if it's irrational, so we said, so the likelihood of having a bad outcome with refractive surgery is very low, but still for many patients that fear element is a big element. And then I would add education or indecision, basically explaining, or the know-how or understanding. On top of it comes the challenge for us as companies in delivering new innovation, because I think innovation is one of the big elements to address those challenges, is of course regulatory barriers which are increasing, regulatory approvals which have made developments more challenging. So our vision at Schwind is better quality of life. So today, and the number actually increased a little bit since it was here today. We do about 4,000 treatments every day on Schwind devices. So all you doctors together, about 4,000 treatments. So a happy patient getting up from a patient bed every 40 seconds. So that's already a nice number, but the target is of course to increase that to more than 8,000 in the coming years. So that's our daily motivation. And I think what is better quality of life for patients? So we, on one hand, as we know, uncorrected refractive error is the single biggest cause of visual impairment. So there's a huge opportunity for easier and better life for patients. And as I mentioned, and that's why I was astonished by this cost comment, actually over a lifetime, refractive surgery is actually a cost positive surgery for the patient. So there is let's say a big opportunity here. And lifestyle improvements, of course, we have seen it during COVID, where there was an increase in refractive surgery because all the fogging on glasses, and because people had time and money to spend, which they saved on vacation and restaurants. So if we take a broader perspective on the market is growing, as I mentioned. There is a huge opportunity. That's where we see the opportunity for laser vision correction. From our perspective as a company, we think the excimer is here to stay. So we speak about lenticule. Yes, femto is a big opportunity going forward, and there's still a lot to be discovered within femto, but we think the excimer is here to stay. At the same time, we see a convergence to some extent of to lenticule and surface treatment. So if you look at countries with a very high portion of lenticle treatment, like South Korea, for example, the number of patients treated by surface treatment is still relatively similar, around 20%, whereas there is a lot of conversion of LASIK towards lenticle, and now South Korea has almost 70% lenticle, and the remainder of 10-15% is LASIK. And then the last element for us is also to say we have been focusing as a company, our culture has been very much to focus on results on the cornea. And I think that's the number one topic, to give the patient excellent vision. At the same time, we realize that for you as surgeons, especially if you have multi-center clinics, that workflow and data flow becomes more important, providing a platform for you. And also the whole communication and education part, providing you with materials to communicate to patients and communicate the benefits of refractive surgery to patients. So great results for better vision. Just to summarize, so we have always been driven by using objective data to provide excellent quality results with the device. So using diagnostic data, feeding that into the laser, and that's what we also do now with the Atos. And now the next step with Centrax, which Kishore mentioned, where there is this reference point of the visual axis coming from the diagnostic device. That has accompanied us over the past year of, let's say, milestones and innovation track record. So as mentioned, Kishore mentioned, we brought the Atos to the market with objective diagnostic data. Also because we were thinking, I mean, you have been used to having an excimer with eye tracking, with a transition zone, with cyclotorsion compensation. So from our perspective, we said there is no reason why you should compromise in doing lenticular surgery. I mean, this has set the standard, so I think we should build on that standard. OCT connection I mentioned, which is available not inbuilt yet. I don't know, it's a bit more complicated, but this is something which has been on our minds for a while. Let's see, it's not really on the roadmap yet, but we'll certainly reconsider it. But an OCT connection in terms of using the data both for Amaris and Atos, and now a program called Foresight, where you can do you can look at your results pre-op, so you can look at your post-op day one results before doing surgery, so doing the step into predictive surgery, and Centrax I mentioned already. So at the same time, without going into too much of the details of this graph, I think, yes, the product, of course, is important in the middle, but everything which goes with it, so the whole workflow part I mentioned, but the application support and the service, and here in India, as you know, we partner with Care Group as a strong partner, so I think that's important for you as well, because the complications you have seen, and as Kishore mentioned, especially with lenticle, the learning curve is a bit, takes more time, and that's where it's important to have skilled application people who can support you. And especially for Atos, we said we don't want to settle. We have been a bit spoiled with an Amaris, which has done well in the market, and so our application team thinks, oh, if the surgeon doesn't call, it's okay, he must be happy. And now we're telling them, no, guys, we have an expectation. We think the Atos can deliver 20/20 next day, and we think 80% of your patients should be 20/20 next day, and if you don't get there, we'll support you to get there. So I think turning it around, let's say even if the surgeon is happy, if it doesn't meet the general expectation, that's where we should get to. So we have developed a program where we support you over at least 12 months and have regular touch points to understand where your vision quality is for the patient. Foresight I mentioned, so looking into the future, that's the start. Now the first edition is about next day planning before you do your surgery, and the target is to evolve that and collect more data and have a tool where you can include, where epithelial regrowth is included, and where you can look at 6 months or even 12 months post-op before doing your surgery, and then adjust your surgery and simulate that and understand what's happening to your results. So this is basically the environment, let's say, around the product. Of course, the product is important as well, and as mentioned, we want to continue innovation on the excimer side, because we think there's still room and need for having an excimer for doing surface treatment still, even though there is a target of bringing surface treatment to the femto as well. At the moment, surface treatment to do customized treatment, so personalized treatments for your patients, to do post-keratoconic correction and adjustments. These are all things which today at least are not possible on a femto yet. Supporting you in bringing this understanding to the market, and we have now also patient material for customized treatments for the MRIs, for example. On the Atos side, as mentioned, the target was really to transfer what we have done with the excimer in terms of transition zone, in terms of the shape of the cut, the large optical zone, cyclotorsion, centration, to transfer that to the femto. So that was basically the first edition, and now taking the next step, what Kishore mentioned, Centrax, which will be commercially available now from roughly April onwards, also allowing you to visualize the dose, because that concept also which was shown earlier of the dose is not always easy to calculate, but for you to or understand more easily, if you change track and spot distance, what impact does that have on my total dose? We will visualize that in the device so that you can play around with your settings and have a direct feedback on that. Intracorneal ring segments will also be added now in April with the next edition, where you can basically do tunnels for either artificial or rings, let's say corneal rings, and correct vision for keratoconic patients. Simple astigmatism is already included now, actually, and to some extent simplification or adjustment alignment of the graphical user interface. That's more midterm, to have a similar perspective for MRIs and the Atos, and of course new applications. So as I mentioned, like what Kishore showed you in the past earlier. So this is the near future, though the bit further future, we think there's still more to be done in refractive surgery. One of the topics we are working on is laser-induced refractive index change. So that, from our perspective, would be a game changer, because it takes out the fear element, basically, because there's no cut. It's basically changing, or the idea of changing the relationship of collagen and water in the cornea with a femtosecond laser, but with femtosecond pulses which are below the gas bubble threshold. So it's like similar to creating a diffractive lens in the cornea. So that works in hydrogel. That is being done already. I mean, on an experimental level, it works in either intraocular lenses or contact lens type material. It does work in the cornea, but one of the big question marks is the stability, and to what extent there is a healing effect in the cornea or not. So those are the things we are working on to show the stability of that. But what that would be, of course, quite a disruptive technology. Unfortunately, it's going to take a few more years to prove that and then bring it into a device also because the technical, let's say the technical parameters for getting it done are relatively challenging. But of course, bringing or having the opportunity to address those remaining 90% still wearing glasses and contact lenses, I think that's where we need to put our thoughts. So to summarize, I think we have a great opportunity, yes, and we can address it together because we are as a company, we're nothing if we don't have super skilled surgeons like you bringing that technology to the market and convincing the patients on a daily basis. So thank you very much. Thanks for being here and happy to address some questions if there are any. Thank you.
Thank you, Dominic. It was such a wonderful presentation and you know what's coming. It's just going to be amazing, I think. So I think we'll take some questions. I think you can be here, put some chairs here. Shashi sir, please come. We'll spend 5 to 10 minutes and then you can ask questions during the lunch because they are all here. So.
You want that?
I would also like to welcome Dr. Sujata. She is our MMC invigilator. Bouquet. Please come. She's taken out time on a Sunday, and we are thankful to her. Thank you, madam. Kishore, please. Sir, please sit. So, any questions from the audience? They are most welcome. You're there. So, any questions? Please ask. You have a mic? Mic आहे का? द्या ना पटकन. एक मिनिट विश्राम नाही तर पुढे ये. अच्छा आहे.
So thank you for a beautiful bouquet of presentations, the concepts. Thank you, Dr. Kishore, for simplifying it so well. So I was just keen to know for a typical maybe a refractive error of about 6 diopters, what would be the typical lenticule thickness that this machine would cut? And what would be the cap thickness, I mean ballpark, taking maybe a 500 or 550 microns cornea?
It depends again on the optical zone. If you make a bigger optical zone, the lenticle thickness will be more. You can make a smaller optical zone, the lenticle thickness will be lesser. So around 15 microns, again your transition is also there. So every laser will have a different setting altogether. So if you look at the Vigimax, has an optical zone of 6 millimeters but a transition of about 0.1. But an Atos will have an optical zone of 6 millimeters and a 0.8. So it's trying to work like the MRS. So the lenticle thickness will be different in different laser platforms. Are you getting me? With a certain optical zone. So for example, the Muller-Lorentz formula, whatever you put in an optical zone of 6, this is about 10 microns per diopter. Okay, suppose. But then the transition will take in a little bit more. The optical zone bigger, it will take in a little bit more. It's like that. But every laser will have a calculator and a nomogram on the laser itself.
So for typically for the Atos?
Yeah, it was there already. It is there on the screen.
Okay.
So on the Atos screen itself, when you start feeding in the pachymeter, this, it will keep telling you. Your residual stromal thickness is this much, your total corneal thickness, post-operative is this much. It will tell you everything there. It is not that you have to calculate through the brain. So everything is on the laser itself. Very, very simple.
And based on your experience with so many cases, have you ever come across any kind of a haze in the interface or anything like that?
Yes, with the haze, with SMILE and Smart Sight, yes, we do get haze. But then most of the haze are due to some complication. Like either it's some pressure eyes or you've had keratitis, something or the other. Like not normal haze. Most of the haze is with the PRK.
Thank you.
Doctor, yeah. No, go ahead.
Sir, is there any cutoff for the minimum corneal thickness that we take here? And or do we look at the stromal bed?
Whom are you asking first?
To the panel.
You can
So, what is your cutoff for LASIK or PRK? Give him a mic, please.
For LASIK, probably 500.
For LASIK, it would be
480 to 500, yeah.
480.
Yeah.
And PRK?
I don't do too much PRK, so
If you did,
probably similar.
similar. We have a senior refractive cataract surgeon from Pune here, Vittal Satha. Vittal, what will be your cutoff for pachymetry?
For PRK, I keep residual 400.
The calculation is like this, 400 should be the residual for PRK.
No, cutoff. Pre-op.
Pre-op.
Total pachymetry.
500.
So, now Kishore will give the last, but before him, I would say I have done about, in the medical college where I was looking after the refractive surgery, I did about 25,000 where we did the pachymetry with the shine fluke system, okay, which is the modern. And 25,000 surgeries means how many, everybody doesn't go to the operation theatre. So how many were evaluated? Maybe not even 30% came to surgery, but they underwent evaluation. So about 75,000 topos with a shine fluke system. I would say in India, the pachymetry, even normally 490, 500, 510 would be what you best you can get, you know. So the cutoff, I would say, should not be typically, it should be racial also. You see in the Gulf, all the patients from Arabs, you know, they've got keratoconus with 580 cornea because the original is 650, 625. So pachymetry has been abused to a certain extent in that way. It is not a black and white thing. It should be taken in a good perspective with other things, topography and all the things.
I totally agree. So pachymetry is something that can misguide you or mislead you during surgery, thinking nowadays so many new things, your scanners, the epithelial mapping, your ORA and your even your Corvis
So let's
kit.
assume the biomechanics is okay. Let's assume the topo is okay.
See, for me, the uncut cornea, for example, a lenticule extraction, the ATOS will tell you your total corneal thickness post-operative. I like to keep it 420. That's it.
Okay.
Okay. So the uncut, so the anterior cornea is strong. You have the strength of the Bowman's membrane also. The uncut cornea 420. I like to keep it like that. You know, because when we talk as surgeons, my complication rate, I would say my ectasia rate, my this rate, my that rate is like 0.1%. Suppose. But whatever, if something happens to the patient, for that patient it's 100% disaster. Yeah? So if you want to treat a patient, it has to be exactly like how you're treating your own daughter or your sister or your mother or your father. So think, if it was your father or your sister or brother, what would you do? Would you take that chance or wouldn't you? You'd get your answer immediately, like, you know. So being more on with the books and things like that, there's so many things that has to come from inside you. Are you ready to take the chance? For me, with the uncut cornea, with LASIK, it is about 300 microns I keep with RST.
Maybe
Thank you.
Just a small addition from a company perspective, we would say our perspective is to say yes, surface treatment has higher biomechanical strength post-surgery, whereas between LASIK and lenticle we wouldn't advise necessarily to have a different. We would say take a similar approach and similar residual stromal thickness. So I think the strength of the lenticle in terms of is more for the patient to, I mean, the dry eye topic we have seen earlier, and the patient being kind of faster in life, if you will, in a sense that the eye rubbing is less of a risk post-surgery and your normal life activities, and not necessarily the biomechanical perspective. I think that's still debated.
This is the management. Just kidding. But the thing is, again, coming back to that, the transepithelial PRK and PRK, the PRK itself, like, because of the, you tend to create another Bowman's membrane already there. So many papers have come up that PRK is like back, coming up to be the strongest procedure. And if you see, like, when you do cross-linking, you're creating a scar. Okay, and you see patients with haze, they have the strongest corneas. So even with PRK, you lose the Bowman's, but you already have another Bowman's already. With a small inflammatory membrane, it becomes stronger and stronger. So LASIK and the lenticule procedures, they have a similar strength. It doesn't, like, immediately, when you look into the biomechanics with LASIK, the LASIK would look much, much weaker. But once the flap heals and there's scarring at the edge, the lenticule and the LASIK flaps, they're the same. Yep.
Anything for hyperopic treatment?
Yes, you have LASIK, you have trans-PRK. Yes, and then you have the lenticules coming. I think the Visumax has come up with the lenticules.
Good afternoon, Dr. Kishore from Nepal. I'm Dr. Bakshi from Mumbai.
Hi.
Mumbai, that city that never fears. But still, you could instill a lot of fear in us, not only in our patients, but including me. I have a lot of questions, but I'll keep it to the relevant ones. My question was that, you said that the number of swipes that you make usually causes a delayed visual recovery. So isn't it a counterintuitive that you would do one swipe rather than multiple swipes? And a fantastic talk, Dr. Nitin, but what would be the ideal number of swipes per se, or what is the technique? That is number one. Number two is, as I understand it, is patient dependent, machine dependent, and surgeon dependent. A lot of it has been solved on the patient dependent and the machine dependent parts, but the surgeon factor still remains in terms of the technique. So intraoperative OCT is one of the suggestions. Wouldn't it be also very easy to put a slit lamp cross section which you can put it up, and would that give a fairly rough idea of what kind of plane you are in?
There is a slit lamp in the MRS. So if you have an MRS and an ATOS, there is a slit lamp on the MRS. But again, like, let's look at it like this. Let me answer his question first. Okay. I haven't finished. So coming back to the hyperopic lenticules are already ready, but it's going to come probably by the mid-2026, end of 2026. With the Visumax, I think I was the one who did the clinical trial. I've done 300 patients. I think they've launched it with the 800, but I don't know, I haven't seen anybody talking really of it. But whatever they're showing is they're still showing that my 2014 clinical trial slides are still being shown. I don't know how the results are now, but because there are two softwares, I don't know which software they're doing it, but we have priorities that come up. So cornea surgeons want cornea, so probably cares, the rings, all these will come in first, and then with the Centrex, then we'll have mixed astigmatism, and only then the hyperopic. So hyperopic, because I'm the most excited guy, so probably they'll put the hyperopic last, so that I do most of the things first.
It's not that so let's say our perspective so far has been that first of all, you have an excellent hyperopic treatment with the ATOS and the MARIS combined. Hyperopia tends to have a slightly higher risk of regression because of the adaptation and so forth. You know that better than I do. That's why we think it's a surgery which is still easier to be done on the excimer. And then, of course, having a hyperopic, let's say, lenticle shape is more challenging. I think with our, let's say, edge going to zero, it should be quite a bit easier. But for example, if you look at some of our competitors having a minimum thickness already, then you add even additional thickness. So we're not sure that's so easy. So yes, we will look at it definitely. We just think they are, unfortunately, we are in a world of limited resources, including our R&D people. So from that perspective, we want to focus them on other topics which we think are more appealing, maybe on a short run. Femtotranspir is one of the topics. Customized treatments potentially in lenticles is one of the other topics which where we have experience from the examiner, and definitely hyperopia is also on the roadmap. The question is more whether that's the next application, or that's going to be the one after the next, or maybe the one after the next. Let's see.
So coming back to your question, one sweep, like you saw that one sweep, it looks very easy, but nobody asked me what the dose was. Okay, so probably the dose was very high. So we want to do things like, make it very, very smooth in one sweep at very low dose. That would be the perfect ideal thing to do. But then it is not very easy. Like you see you go to some lenticule congress, someone is just holding the lenticule edge and tearing it, and wow, he's getting a lot of claps, and the next day the best corrected visual acuity is 20/40. Okay, something like that. So what we just talked about, how we try to keep the dose low, keep the corneal edema low. So for that, I don't think that one sweep is like sometimes not very easy to do it, but try. When we were doing this study, I looked into my surgeries, and then I realized that we were doing, the number of swipes I was doing was 32 times. And then I tried and reduced, it came down to 17 times. Now I think it's about 12 or 13 times still.
And that will be our...
Can I quickly ask him, so if it's 12 times, so how soon does the patient get 6/6 vision?
For me, it's like...
On the same day? Or
not
next
same
day?
Next day. Yeah.
Next day?
Yeah.
Okay.
That will be our, it's management perspective, yes, so I'm not the expert, but that's our experience as well, to say there's a trade-off, of course, as Kishore said. We would, from an application perspective, we would support to say go for low dose and try to find the optimum rather than optimizing for cut, because usually the lower dose brings you faster recovery than the ease of separation.
Yeah. So it's like you get 6/6 the next day, and the patients have stopped asking me, when will my vision come back? So 5 years back, the patient is still reading 6/6, and they were like, doctor, by the way, when will my vision come back? Like just before leaving, and that makes you so sad,
So is it the surgical technique which is improved, or the dose?
The dose. Yeah.
Okay. Dr. Nitin, I had a quick question. You had, what I gathered is about 70-80 patients who's have been done here. So now it's all set. The parameters and your connections are set. So it'll be easier for us to get patients and get it done from you, right? Or
so initially there is a struggle to set everything, but now things are fine.
And final question: after what time can the patient swim? Because it's a very common question that they ask, that they want to swim, get back to swimming. So is there any difference between the LASIK protocol and the ATOS protocol?
So for me, with the ATOS protocol, in Nepal we have these Gorkhas. The British, they go into the British Army, the Indian Army, the Gorkhas go back into commander training after 1 week.
But that is combat training. I'm talking about swimming.
Yeah, but that combat training is full of mud. So swimming is much better. So
much easier. Thank you. Thank you. I have a lot of questions, but I'll leave it to the rest of the audience.
No, you can fire them actually. Be very relaxed,
Is there any questions or comments?
For retained lenticule or...
See, this is what I'm saying. I've never had a retain. I still, at the beginning with the Visumax, I did have a lot of torn lenticule. I've never had a torn lenticule over here. Probably because I'd already done 10,000 smiles before, something like that. But
it's not very easy to tear it. You have to be really rough, Otherwise, comes out pretty. But there was a video presented with triamcinolone staining the edges.
Yes.
So with the, it was mentioned with the telecentric scanner, we think, I mean, we haven't proven it with a study. It's difficult to compare one to one, but because your scanner is perpendicular, or the laser is perpendicular to the cornea on all places of the cornea, and that's why the separation in the edge is let's say better, and thus that should reduce the tear in the atlas. And actually, it's not a complication we see in, let's say, worldwide surgeries. I can't recall any patient complications we had on lenticle tear.
So there was a quasi-centric cylinder.
That's
which
the
was
same thing, yeah.
So
That's
what
the
is the
scanner.
diameter of the, or how does it, what is the diameter of that cylinder which is
I
right?
don't know, yeah.
Approximately?
But I don't know.
I mean,
really
the
don't
total
know.
optical zone is which you can cut is 9 or something like that. No,
No, he's
Sorry,
talking
I'm
about the
sorry.
diameter of the
Yeah, the diameter of the
scanner.
cylinder.
I don't know, yeah.
Okay. Because,
Because the cone is about, how much? 12 millimeters?
12, yeah.
So it's in the center, so it should be around 6, something like that.
maybe
around
it covers
6
the whole optical zone
zone.
because it doesn't move actually. The cylinder it just turns.
Yeah.
So we don't move it during surgery. So it's static. So it covers the whole optical zone.
Okay, so
I don't-
my next question was, that's how it does it perpendicularly rather than, I mean, if it's a smaller, look in the video, that's very, very small, like a 3 millimeter or maybe smaller than that.
Yeah.
But if it's 6 millimeter cylinder, then it could cover the spots on a perpendicular plane.
Actually, I think it's more than 6. I mean, it must be
More than
around
6.
10 or something like that, but I'm not sure. Yeah, as I said, during surgery, it doesn't move laterally. It covers the whole
only
optical
spinning,
zone
yeah.
basically. It's only spinning. Yeah.
Yeah, so Shashi sir, any concluding remarks?
So I think, the conclusion is always to have an entire armamentarium, like there's a LASIK, there's a role for PRK, there's a role for LASIK, like Nitin has taken his journey every step through the way. Today it has come to a lenticule, but he would be free to use all the armamentarium at his disposal and see what is best for the surgeon, and that same thing for all of us. So we need not be particularly tied up to a particular procedure, and you've got everybody's contacts, and you can, I'm sure everybody's available to be contacted on email, YouTube, or whatever it is, and wish everyone best of luck. Thank you, Nitin, for a wonderful morning.
Thank you, sir.
And Damon and Kishore, thank you.
So,
Thank you so much. Mumbai, thank you so much. Mumbai is always in Bollywood.
So we'll break for a quick lunch. You can, they're there, and after the... चलेगा caps. So after lunch, we would like to, those who have registered for a wet lab, we would like to start wet lab by 2:20. So we have half an hour, and my center is just walkable from here. 5 minutes. So my people will take you there in groups, and we will start wet lab there. So lunch is at the back. Lars, मेरा कैब ऐड हो गया